All right. Assalamu alaikum wa rahmatullah. Thank you very much for the nice introduction. And I would like to thank Astellas for giving me this opportunity to present this satellite symposium. I will talk about relapse refractory AML, specifically about FLT3 AML. So nowadays we rely heavily on molecular profiling for diagnosis of acute myeloid leukemia, and this will help us actually to identify the right subclass of AML and identify the risk that is associated with this disease, and also will help us to choose the proper treatment, proper targeted therapy nowadays we have, and also as a tool for MRD monitoring. So AML is a heterogeneous disease. It's genetically defined disease. So we rely heavily in the genetic profiling of the AML to subclass the type of AML as well as risk stratification. So genetic profiling is very important here in terms of risk stratification, so you can know what type of treatment that you want to start in upfront setting and also in relapse refractory setting, and before that also what kind of consolidation you would consider for this patient based on their genetic profiling. As we know that FLT3 is one of the most common genetic mutation that we see in AML, constitute more than 30% of patients. Majority they have the ITD mutation. Very few, less than 10%, they will have the TKD mutation. And as we know historically, FLT3 has been associated with poor outcome for patients treated with standard induction chemotherapy. Nowadays, we have multiple agents approved for treatment of FLT3 AML in different indications. We have two types of FLT3 inhibitor. We have the type 1 FLT3 inhibitors, which actually targeting both the ITD mutation and the TKD mutation. Example for that is midostaurin and gilteritinib. And we have type 2 mutation, type 2 inhibitors, which specifically targeting only FLT3 ITD. An example of that is sorafenib and gilteritinib. In the upfront setting, the RATIFY study led to the approval of midostaurin as the first ever targeted therapy for acute myeloid leukemia in upfront setting after this randomized study, which include patients who are FLT3 ITD positive and FLT3 TKD. This study showed a significant improvement in overall survival for those who received midostaurin in the induction and consolidation phase, followed by maintenance for those who did not go into transplant without randomization in between. And the median overall survival was 74 month versus 25 month midostaurin versus placebo. And what's remarkable here is if you look to the patient who went into allogenic transplant while in CR1, they have a significant remarkable improvement in overall survival. Thinking about the role of utilizing the FLT3 inhibitor within the upfront setting during induction and consolidation, followed by stem cell transplant, knowing that maintenance midostaurin was not allowed in the post-transplant setting in this situation. So you can see that there is a remarkable overall survival curve here for patients who receive transplants in the upfront setting. Similarly, more recently, quizartinib, which is FLT3 specific, has been approved in the upfront setting based on the Quantum first trial. Again, newly diagnosed AML, but FLT3 only patient who received quizartinib in the induction, followed by and consolidation as well as maintenance. And you can see that there was an improvement in overall survival. The median overall survival of 31.9 months for quizartinib versus 15.1 months for placebo. And again, patients who went into allogenic transplant while in CR1, they actually have the best outcome for those who receive quizartinib in the maintenance as well. So what happened to those who relapse after upfront setting for FLT3? The outcome is dismal. Some of them they will still retaining the FLT3 positivity, and some of them they will have FLT3 negative relapse. And the pattern of resistance, or the kind of disease that relapse after the use of FLT3 inhibitor in the upfront has been evaluated based on multiple data. Specifically for those who receive type 2 inhibitor, which is specific for ITD, they usually relapse with the FLT3 TKD, and they have worse prognosis compared with those who do not. And for those who receive the type 1 inhibitor, for example, midostaurin, they will have mutation, or they acquire mutation in the RAS pathway, and they do have worse outcome. So within the relapse refractory setting, I'm discussing here the Quantum R study, which evaluated the quizartinib in the relapse refractory setting for a FLT3 ITD patient. They enroll patient age above 18, and then they should be a FLT3 ITD positive patient. And in this study was compared to salvage chemotherapy, which was MEC in 33% of patients, FLAG-IDA in 43% of patients, and 24% of patients, they went into low-dose RSC. And the primary endpoint was overall survival in the intention to treat population. It showed an improvement in the median overall survival, meeting the primary endpoint with 6.2 months for quizartinib versus 4.7 months for salvage therapy. And this led to approval of this medication in Japan many years ago. Gilteritinib, as I said, is a type 2 inhibitor, which targets type 1 inhibitor, which targets both TKD and ITD, and has been evaluated in the Admiral study, which meant to investigate the benefit of gilteritinib in the relapse refractory setting, FLT3 ITD and TKD positive. And the patients were randomized to receive gilteritinib and salvage chemotherapy, and the primary endpoint was overall survival and response rate as well. So as you can see here, if you look to the patient characteristics, median age was around 62, and majority of them, they were intermediate, which is typical for FLT3 positive patient. And around only 12 or 13% of patients, they actually had FLT3 inhibitor prior exposure, and around 20% they were relapsed post transplant. Looking into the type of pre-selected salvage chemotherapy, around 60% of patients they were selected for intensive chemotherapy, which was balanced between both group. Majority of patients, of course, they have ITD mutation. The co-primary endpoint was the CR, and CRH was met with the gilteritinib showing 34% CR/CRH versus 15% for salvage therapy, and the CR rate was actually 20%, 21.1% in the gilteritinib versus 10% in the salvage arm. And the overall survival endpoint was met with the improvement in overall survival, showing that gilteritinib had 9.3 months versus salvage chemotherapy of that had 5.6 months. And looking into post-hoc analysis, those who went into transplant, they did actually better, thinking about this as a bridging way to go for allogenic transplant. Different subgroup showed similar benefit from the use of gilteritinib in this study. There was no significant safety concern when it comes to use of gilteritinib in the post and the relapse refractory setting. Again, the similar study was replicated in Asia. They call it the Commodore trial, having the similar patient population, phase 3 multicenter open label study, which showed again gilteritinib arm showing a median overall survival of 9 months versus 4.7 months for salvage chemotherapy. So this makes the gilteritinib as a standard of care for relapse refractory FLT3 ITD patients. So thinking about the role of FLT3, so we talk about it in the upfront setting, in the relapse refractory, and now we'll talk about it in the post-transplant setting and the role of maintenance. We should keep in mind whenever you think about maintenance in AML, this should have suppress the evolution of the residual leukemia, and this should be should not add a lot of toxicity for those sensitive patients, and also should have an ease on administration and reduce the frequency of monitoring. Because if you think about giving prolonged maintenance therapy for 1 or 2 years and mandating the patient to come to the hospital and getting like subcut injections or IV injection, this will be not feasible for patient with AML. And specifically for post-transplant setting, this should not increase the risk of graft versus host disease, should not affect the risk of graft versus leukemia as well, should not lead to any cytopenia, which is very important in that situation, and also should not interact with the post-transplant medication, including anti-infection prophylaxis and immunosuppressive medication. So there's a delicate matter here we should handle when we consider using maintenance therapy for patient post-transplant setting. So there are multiple randomized studies done in the post-transplant setting, and we will discuss some of them. So sorafenib maintenance was evaluated in a Romaine study, including a patient with FLT3 ITD. It's a phase 2 randomized study. It has relatively small number of patients, around 40, 45 in each arm. And they were randomized to use sorafenib versus placebo, knowing that not many of patients in this setting, they receive FLT3 inhibitor in the upfront setting. So majority of them, they are FLT3 naive. And also they include some patients with relapse refractory disease as well. So patients were randomized to receive sorafenib versus placebo, and you can see it's met its primary endpoint with a significant improvement in relapse-free survival, with a 2-year RFS of 85% for sorafenib versus 50% placebo, as well as overall survival improvement, trend toward overall survival improvement with a 2-year of OS of 90% versus 66%. There was no MRD data driven in this study. Subsequently, Chinese group, they published their experience with the use of sorafenib in a phase 3 open label randomized study, relatively higher patient, almost double the number from the previous study, using sorafenib versus control, because this was an open label study. And what we should highlight here, that majority of patients, they are younger population, which is not what we usually see with the FLT3, and also all patients universally they use myeloablative conditioning regimen, and less than 50% of patients, they were exposed into sorafenib. Around 27 or 30% of patients, they use sorafenib in upfront setting, and the rest, they actually use it in the relapse refractory setting. So again, homogeneous population, newly diagnosed relapse refractory in this situation, indicating high-risk patient population. Still, we can see that the sorafenib led to much lower incidence of relapse, improvement in leukemia-free survival, as well as overall survival. Midostaurin was tested in the post-transplant setting, which did not show any improvement in the outcome. So this was a negative study. And more recently, the MORPH trial reported the use of gilteritinib in a post-transplant setting as a maintenance post-AML for FLT3 positive AML, including ITD patient only. And in this study, they randomized around 178 patients in each arm between gilteritinib and placebo. The study did not meet its primary endpoint, where the relapse-free survival, there was a trend toward improvement with gilteritinib, but thus was not statistically significant, with a 2-year RFS of 77% in gilteritinib versus 69.9% in the placebo arm. And also there was no improvement in overall survival as well. And you can see still the placebo group, they did actually remarkably well, comparing them with the previous study. But what was interesting here, that there was robust MRD data compared to the previous 2 studies. So robust MRD data using ultra-sensitive BCR NGS assay that detect at deeper level the residual FLT3, and this MRD data was maintained throughout the study, And what they found that there was actually benefit for those who were MRD negative. So looking into patients who were MRD negative pre-transplant and receive MRD positive pre-transplant and receive gilteritinib, they have improvement in relapse-free survival compared to those with placebo, while you can see MRD negative population in the right hand, there was no benefit of gilteritinib. So as I mentioned, this is just to show you the percent of patients they were analyzed. They have an MRD data around more than 90% of patients actually they do have an MRD data. In the pre-transplant setting, 46% were detectable in their MRD, and in the post-transplant, around 20% of patients they have MRD positivity. So overall, 50% they were MRD positive, and whether patient have MRD positivity pre or post-transplant, gilteritinib use was actually associated with better outcome. So in conclusion, FLT3 ITD has very low probability of achieving second CR in relapse setting. So novel agent is needed in this situation. Gilteritinib is the approved indication and the only approved indication in this situation in relapse refractory AML. I think MRD assessment is very critical now to think about it, especially for patients to go into allogeneic transplant to determine what kind of maintenance to be used in the post-transplant setting. With that, I conclude and happy to take any questions.